The topic of my presentation today is current status of pre and post-transplant alcohol monitoring protocols in Korea. In Korea, according to statistics from the National Institute of Organ Transplantation, LT due to ALD has fourfold over the past 15 years. It was confirmed that all liver transplants, the distribution of liver transplant due to ALD was 7.1% in 2009 and 20.3% in 2012, and especially as of 2022, 40% of liver transplants from brain dead donors were confirmed to be caused by alcoholic liver disease. Alcoholic liver disease is one of the main causes of cirrhosis and liver failure, and liver transplantation may be required. The number of ALD cases due to ALD is increasing. In the United States also, LT due to ALD has increased fivefold over the past 20 years. The relative increase in LT in ALD patients is due to a decrease in the number of patients with hepatitis B and C, which were previously the main indications for LT because the development of therapeutic agents and prevention of causes. In addition, alcoholism is now considered a chronic and relapsing neurological disorder with a clear biological basis, which has contributed to the change in attitude toward ALT as the main treatment for ALD. Alcohol relapse after liver transplantation can have a long-term impact on the transplanted liver and patient survival. The prevalence rate of alcohol relapse in liver transplant patients with ALD varies across studies. Reported post-transplant alcohol relapse rates in recipients with ALD range from 15% to 50%. In Korea, in previous studies on LT for ALD, alcohol relapse after LD ranged from 3 to 49%. So, despite the success of liver transplantation in ALD treatment, one pressing issue remains the risk of alcohol relapse in transplant recipients. Therefore, the relapse rate of alcohol use is a problem in liver transplantation of patients with alcoholic liver disease, and ethical issues related to the equity and efficiency of liver transplantation are discussed. For the above reasons, the use of a strategy to prevent alcohol relapse should be attempted to solve the current problem of alcohol liver transplantation. Strategies that can be used include predicting and assessing the possibility of alcohol relapse before and after transplantation, which requires the application of interviews, questionnaire-based surveys, biomarker assessments, and psychological assessments. The importance of a pre-transplanted intervention such as alcohol abstinence programs has been confirmed, and the intervention of continuous alcohol monitoring tests after transplantation is evaluated to be of great help in preventing relapse. In particular, collaboration with the transplantation team is fundamental to providing comprehensive treatment to individuals recovering from alcoholism. And an approach in which a multidisciplinary treatment team consisting of transplant coordinator, a hepatologist, an addiction specialist, a psychologist, and social worker works together to ensure that the patient receives holistic health support is essential to improve the quality of treatment and to ensure continuous abstinence in transplant patients. However, in most Korean centers, systemic management protocols do not seem to be as well established. Furthermore, it remains unclear how centers manage LT for ALD patients. At 2023, the Korean Liver Transplantation Society conducted a multi-center survey to evaluate the ALD-ALT management protocol in Korea. Among 74 liver transplant centers in Korea, 19 centers were recruited for survey to investigate the status of alcohol patient management in Korea. They developed a survey questionnaire to investigate pre- and post-management of patients with alcohol-related liver diseases. The survey responses from all 19 centers were completed between February 1st and February 29th, 2024. Among the 19 centers, that responded to the survey, 17 were tertiary general hospitals and 2 were secondary medical institutions. In 2022, the number of LT performed at each center per year was as follows. 16% were less than 10, 53% were 10 to 50 cases, and 21% were more than 100 cases. All 19 hospitals have been performing LT for patients with ALD for more than 5 years. Additionally, by 2022, the annual accumulated number of patients undergoing LT for ALD at each center was as follows. Most 37% were 5 or fewer, while the other accounted for 21%. Out of 90 centers, 10 centers responded that they required a period of alcohol abstinence before evaluating LT and registering for the transplant waiting list. All 10 centers required a minimum abstinence period of 1 to 6 months. 15 centers monitored alcohol abstinence before LT. Duplicated responses were allowed for the methods of monitoring alcohol abstinence before LT. 15 centers used direct patient interviews, and 4 centers relied on external report. Pre-transplant abstinence monitoring using alcohol biomarkers was not performed in any center. Only 2 centers reported having protocols in place to assess alcohol consumption during the waiting period for LT. Only 1 center used the scores from the audit. Alcohol use disorders identification test consumption tool. The protocols used in both centers included a visit to a transplant surgeon, 10%, and 1 center included a visit to a psychiatrist staff member, 5%. The protocol did not include a chemical dependency evaluation or social worker visit. 14 centers, 74%, provided counseling from a psychiatrist before transplantation for patients with alcoholic liver disease. 5 centers, 26%, established treatment plans for alcohol use disorder before liver transplantation. 70 centers, 89%, monitored abstinence from drinking after LT, with 7 centers monitoring abstinence monthly and 10 centers monitoring abstinence at 3 months intervals. Direct interviews were used to monitor abstinence from drinking after LT at 17 centers, with 3 centers additionally checking external reports. Alcohol biomarkers were not used to monitor alcohol abstinence after LT. Only 5 centers have protocols for relapse alcohol after transplantation. The main components of the protocol include visit to transplant surgeons, 5 centers, psychiatry team, 4 centers, chemical dependency evaluation, 2 centers, social worker, 1 center. Most centers perform abstinence monitoring after LT, but the frequency varies, and most abstinence assessment methods have been direct patient interviews, with alcohol biomarker rarely used. In the United States, alcohol biomarker plays an important role in monitoring alcohol use in patients with ALD, and serum PEth is almost universally used to monitor alcohol use before and after LT for ALD. In addition, most centers did not have a protocol for assessing alcohol use before LT, although most consulted a psychiatrist before transplantation. Few had a treatment plan for AUD before transplantation. Furthermore, in very few centers, psychiatrists managed alcohol relapse after LT. In Korea, assessments that include a multidisciplinary social psychological team appears to be lacking. More proactive and consistent protocol guidelines are needed that take a multidisciplinary approach that includes not only surgeons, but also hepatologists, psychiatrists, and social workers to assess and treat AUD before liver transplantation. In the United States, there is no standardization of practice or policies across transplant centers, nor are there any quality metrics from regulatory organizations specific to alcohol. There was an article in 2023 arguing for the need for national standards and presenting new best practice in 3 categories: candidate selection, alcohol use monitoring, and harmful alcohol use prevention and treatment services. On June 15th, at the first Harvard seminar of the Korean Liver Transplant Society, a case presentation on the My Liver Guidance Program to prevent the relapse of drinking in liver transplant patients was given. And the need for collaboration between hospitals and the National Addiction Management Integrated Support Center was suggested at that time. On July 3rd, the Korean Liver Transplant Society held a joint meeting with the Korean Association of Addiction Management Centers and Korean Society of Addiction Psychiatry to discuss a multidisciplinary approach to the management of alcoholic liver transplant patients. After discussing collaborative tasks, we plan to develop a protocol for liver transplant patients' management due to alcoholic liver disease by forming a multidisciplinary collaborative team consisting of transplant surgeons, psychiatrists, organ transplant coordinators, and social workers. The developing together a alcohol prevention protocol. The developed protocol is expected to suggest Korean alcohol monitoring system. It is also expected to contribute to policy changes for alcoholic liver transplant patients. The current status of alcohol monitoring in Korea suggests that alcohol monitoring is important from the LT selection stage. In particular, the use of validated assessment tools and the application of systemic assessment methods using biomarkers are necessary. A multidisciplinary team approach, including addiction specialists, should be activated. Qualitative research is needed to enhance health field application, and data management related to alcohol relapse rates is necessary. The development of standardized monitoring protocol is necessary for equity and quality control of liver transplantation surgery. Today that's my presentation. Thank you for your attention.